With regard to instituting BiPAP, you make this recommendation to the physician. He agrees and asks for an IPAP of 15, an EPAP of 10, an FiO2 of 70%, a backup rate of 8. Remember, BiPAP is indicated for people who are spontaneously breathing. We're also using a small nasal mask and a chin strap to keep our mouth closed. We repeat a blood gas after placing the patient on these settings on BiPAP. Patient still breathing 28 breaths per minute on the BiPAP. And our FiO2 has been weaned to 40% because we've been watching our SpO2, and we've been able to turn our FiO2 down on the BiPAP as we go. And here's our blood gas, 7.3, still has a slight acidosis due to that metabolic problem. Bicarb's a bit low. Her CO2 looks okay, and her PO2 has shot up now to 124 with the 10 of EPAP and the FiO2 of 40%. We are concerned that the patient's still breathing 28 breaths a minute. We think that perhaps her tidal volume is a bit low. People who are weakening have low tidal volumes and high rates, so we're hoping that if we increase her tidal volume some, her rate will drop. And we can do this, increase this tidal volume, by increasing the pressure support. Remember, the pressure support is the difference between the inspiratory pressure and the expiratory pressure. In this case, we have an IPAP of 15 and an EPAP of 10, so the pressure support is 5. So we're going to try to up that pressure support some. Two ways that can be done. One is by increasing the IPAP, or what we're going to do in this case is decrease the EPAP, because it seems like we don't need an EPAP of 10. We might be able to get by with an EPAP of 5 since our oxygenation has responded so well. So that's exactly what we're going to do. Bear in mind that EPAP affects the oxygenation and the pressure support affects the carbon dioxide. And so we do that. We turn our EPAP to 5 and leaving the IPAP at 15, and now we have a pressure support of 10. Hopefully that will increase the tidal volume. It seemed to work as the patient is now breathing 20 breaths per minute on the BiPAP. In fact, we can watch the tidal volume. It's pretty accurate on the vision. She's also maintaining her SpO2 at 95% on that 40 and 5 of PEEP. Her follow-up blood gas reveals a pH that's normal and a normal CO2, so no further changes are suggested at this time. Further assessment reveals that the chest x-ray shows bilateral densities, increase in heart size, and a small right pleural effusion. The CBC shows a normal white blood cell count, and the patient has some anemia. The radiologist feels like this chest x-ray is suggestive of pulmonary edema like you'd see with heart failure. The CBC, the fact that the white count is normal, suggests that there's not infection, possibly pneumonia. And the reason the patient was not cyanotic was because she was anemic. Remember, cyanosis is a sign of desaturated hemoglobin, and anemic patients rarely show cyanosis unless their oxygen is deadly low. The emerging clinical picture suggests a patient in heart failure with pulmonary edema. In order to treat this, the patient is started on Lasix to decompress the vascular system, cardiotonics to increase the heart function, and drips to help with systemic vascular resistance. Although the case seems like heart failure, early pneumonia or other bronchial infection can't be completely ruled out, so the patient started on nebulizer treatments, possibly IPPB, to help with the bronchial hygiene problem or potential bronchial hygiene problem. Patient's also scheduled for a VQ scan to help rule out pulmonary. After 12 hours of therapy, the patient's condition has improved dramatically and the patient's weaned from her BiPAP. The nasal cannula is resumed. No evidence of pneumonia or pulmonary embolus was found. Good outcome. As a discussion, BiPAP is most successful at preventing intubation and mechanical ventilation if instituted early at the first sign of respiratory distress. Some of the significant risk associated with intubation and mechanical ventilation, such as ventilator-associated pneumonia, can be reduced by the successful use of BiPAP. BiPAP is most successful at reducing or rescuing individuals with early hypoxic respiratory failure and less successful at rescuing individuals with significant hypercarbic respiratory failure. I realize that patients need to be spontaneously breathing to put on BiPAP, so it's not indicated for patients who have suffered drug overdose, respiratory arrest, or other causes where the patient's not able to maintain a normal respiratory rate. Failures on BiPAP often occur because of lack of patient acceptance. Some patients become combative when they feel like you're suffocating them with a piece of equipment, or a failure might be indicated by a patient that fails to improve when BiPAP is instituted. In either case, failure of BiPAP usually requires that the patient be intubated and mechanically ventilated, and of course you'll sedate the patient in order to do this.